السلام عليكم ورحمة الله وبركاته. أحد زملائكم أرسل يطلب notes, audio notes or discussion on slides related to lecture of hemodynamic disorders. Quite an important topic with regard to basic pathology. So I'll start from number 46, starting with infarction. So what is an infarct and what is an infarction? So an infarct is an area where you have ischemic necrosis, the result of occlusion of an arterial supply or venous drainage to that particular organ or tissue. And then, so this infarct is the area, we describe the area of ischemic necrosis that's caused by this occlusion. The process of an infarct happening is called infarction, okay? So this is the difference. The difference is that infarction is the process, while infarct is the lesion, it's the abnormality. And what can cause infarction? So can result from a sudden reduction of blood supply to an area. And they are classified based on the vascular supply into arterial and venous, okay? Arterial is the most common, represent 99% of the infarct. Obstruction can occur as a result of thrombosis or an embolus arising most of the time from a thrombus. So when you think about arterial causes of infarction, the classical example is coronary artery disease, in which there is thrombosis of the coronary artery. Most of the time it's the left anterior descending coronary artery leading to infarction of the left ventricle, especially where the area. So the area of infarct, the geography of the area of the infarct follows the vascular supply by the blocked vascular structure, okay, especially في الارterial. نيجي للنوع الثاني. النوع الثاني اللي هو الفينس. And venous happens due to thrombosis. So venous infarction does not happen due to emboli, but happens due to thrombosis in the vein and occurs in problematic organs in which there is single venous outflow, such as, for example, a testis or the ovary. Okay, so because you tend to have a plexus, many tributaries of veins, so the likelihood of developing venous thrombi that can lead to infarction is not as common as arterial. So what does an infarct look like? So it can either look white or red based on the color and the signs of infection. So a white infarct is the classical example. So you see a white area which is like a triangle with the base towards for example, in the lungs, the base will be towards the pleura. For example, in a solid organ, it will be towards the capsules, such as the heart and the kidney and the spleen. And what you sort of see is that the apex of that triangular area will point towards the obstructed artery, okay? And so whether an infarct becomes white or red will depend on the solidity of the tissue. So the more solid the tissue, so solid tissues such as, for example, heart, kidney, and spleen tend to have less of hemorrhage, okay? So they tend to be white. Terminal arteries do not have anastomosis, so the block in these vessels will deprive the tissue distally to the area of the obstruction, resulting in this pale or white appearance. The other type is red infarcts, which occur most of the time due to venous occlusion, okay, so obstruction of the venous supply. So what happens with obstruction of the venous supply? There is congestion. So there is congestion, and with the congestion, thrombosis in the venous drainage will lead to congestion of blood, So the area will be congested prior to undergoing infarction, and as the condition progresses, what will happen is that you will have more of congestion and then infarction developing on this congestion. So the infarct will look red. Other example where you would have red infarct is organs with dual circulation, such as the lungs and small intestine. And so if you have obstruction of the arterial supply, because there is overlap in blood supply because the double circulation, so there will be an area where you will have an infarct, and you will have an adjacent area where you have some blood supply, and this will lead to bleeding. Okay, so the infarct in these organs, the lungs and small intestine, will tend to be red. Another situation where you would have red infarct is loose tissue. Loose tissue, for example, the lung. The lungs has loose tissue, spongy like tissue. So organs with well-developed anastomosis also, such as the brain, also will have red infarcts. Okay, so these are the variables that control whether the infarct will look red or white. So if you look at this is an example from the lung where you have this infarct, and if you look at the apex here, it points to the arterial supply where you have a thrombus, a tiny thrombus here that's blocking all the blood supply. And so you have all this, so the process that's going to happen is infarction here, and look, it has a triangular shape. So this infarct, if you look at it, it's red. Why is it red? Because it's happening in the lung, and the lung is more loose tissue, and there's also anastomosis, so blood coming from other vessels. You will ask, of course, a question, okay, so why does infarct happen when you have dual blood supply? Because the blood supply is not able to meet the demands of the tissue, the metabolic demands, but still blood is going through, right? So you have an infarction, and at the same time you have hemorrhage, you have the bleeding. Look at the next one on the right. So you have a spleen, splenic tissue. Look at how it's like whitish, yellowish appearance. So you have this triangular shape, and so this is another appearance of an infarct. So all infarct wedge shaped with defined margin, and at these margins what happens, you would have an inflammatory reaction going on because necrotic tissue is an irritant, so it causes activation of the inflammatory cells, and so you start the process of acute inflammation going on to chronic inflammation and healing by fibrosis. So an infarct will heal by fibrosis. The dominant histomorphology under the microscope is coagulative necrosis. Okay, so if we take a section from the middle here, what you will see just coagulative necrosis. You won't see much of inflammatory cells, but if you go towards the edges here and look under the microscope, you take a portion of this tissue and look at it under the microscope, you will see the coagulative necrosis, and at the interface you will see acute inflammation, which will start within hours from the beginning of the infarct. And we can use this character to try to date an infarct, especially in infarcts in the heart. So we can know if there's a lot of neutrophils there, that this infarct has happened within the last 24 hours, because there is enough time for the acute inflammation to develop. And then so if we see, for example, macrophages, we would know that it's like 2 to 3 days. If you start to see granulation tissue, we know it's been 5 to 7 days, so and so on. Okay. So there will be a reparative response, either scar or less likely regeneration. Most of the time there is a scar formation. So it depends on how much regeneration there is. So if you're talking about an organ like the liver where it has a high regenerative capacity, the scar will be a very small scar. But if you talk about an organ like the lung, for example, where there is not much regeneration capacity of pneumocytes, if you have also loss of architecture here, there will be a scar. A special type of infarct is infarcts of the brain, which we call liquefactive So it doesn't undergo coagulative necrosis, but liquefactive necrosis. Why? Because of break of lysosomal enzymes. So they break and they lead to lysis and liquefaction of the damaged tissue. Another example, so this is kidney. Look at the kidney here. This is the capsule from the outside, and then you have the cortex, and you have the medulla, okay? And then you have this triangular shaped lesion, right? And so notice that this lesion, the base of the triangle is directed towards the capsule. The apex, it points to the obstructed vessel, okay? So this is an example of white infarct. Again here, remember when we had the discussion about small intestine, so notice the loops of the small intestine here. Notice that this part, look, compare this at the tip of the forceps here where you have normal tissue, so the normal tissue will look pinkish. But look at these loops here on the top. So the loops here on the top are dilated, they're red. So this is the typical appearance of red infarct in the small intestine, okay? So we're done with infarct. Now let's go to shock. We tried to make this topic as simple as possible. I had a good question that I will address. I had some good questions from some of your colleagues, which raise interesting points just for us to understand further this process. So what is shock? So shock is generally systemic hypoperfusion, not able to meet the metabolic demands of the tissue. So can be caused by either reduced cardiac output or reduced effective circulating blood volume. And clinically, these patients will have hypotension. They will have tissue hypoxia as evidenced by decreased oxygen tension if you do pulse oximetry for these patients. And this indicates that there is impaired perfusion and oxygenation of tissue. The major types of shock, the three most important ones are number one, cardiogenic shock, then hypovolemic shock number two, number three, septic shock. So what is cardiogenic shock? It's pump failure. So it's shock that results from failure of myocardial pump, and the causes we divide them into either intrinsic myocardial damage or extrinsic pressure, such as the setting of pericardial effusion or cardiac tamponade, where you have sudden accumulation of fluid or blood around the heart, leading to impairment of end diastolic volume of the heart, or obstruction to the outflow in, for example, pulmonary embolism. That's another mechanism where you would have cardiogenic shock. So the shock that happens in pulmonary embolism is cardiogenic shock. So number two is hypovolemic shock. Hypovolemic shock is more frequent and it's treatable. Why? Because you can simply, if you see that the patient that goes to the emergency department with hypotension, the first thing they do after assessing the patient, they try to determine the cause, and then they would give the patient a bolus of fluid. So hypovolemic shock results from loss of blood or plasma volume, typically caused by hemorrhage or loss of fluid by other means such as vomiting, diarrhea, or patients who have burns and trauma. The third type is septic shock. So septic shock is a bit more complicated with regard to mechanism. So it results when the host innate immune response to infection, which can be either bloodborne or localized in a particular site, leads to hypoperfusion. And the many causes, but the most important causes are microbial infections. And so microbial infections include endotoxic shock by endotoxin, bacterial wall lipopolysaccharide, which is present in gram-negative bacteria, represents 70% of the cases of septic shock. Gram-positive septicemia, such as, for example, organisms such as Neisseria meningitis or disseminated Neisseria gonorrhea, fungal sepsis also. So I had a question, an interesting question from one of your colleagues, is that, so do we need to have disseminated infection or infection reaching the blood for septic shock to occur? We used to think that way, and in the classical teaching, they used to define that, okay, you have bacteremia in which there is presence of bacteria in the blood, detectable bacteria in the blood, and septicemia, where you have bacteria that are dividing inside the blood stream. But it's not that simple or basic. To understand that septic shock results not only from the organism ability to cause septic shock, but also from the interaction with the immune system. So the immune system develops a response which combines the innate immune system mainly, and in this response, which is called systemic inflammatory response, and you can read about this topic more. So systemic inflammatory response involves interaction between innate and adaptive immune system, mainly involves macrophages and natural killer cells and T lymphocytes, CD8 positive T lymphocytes. And so these, what happens is that the exposure to a limited amount of microbial antigen, whether it is bacteria or even virus such as COVID-19, the new virus, or any other type of organism such as a fungus, for example, results in the immune system developing a strong response that is counterproductive. So it's at the beginning the response is protective. It tries to limit the spread of the infection. But if this response goes out of check, it becomes harmful response and results in damage to the endothelial cells and multi-organ damage in the body. Okay, so this explains why even some of the patients who have viral infections can develop a form of septic shock. But in the classical teaching, an example of septic shock is endotoxic shock caused by lipopolysaccharide of gram-negative bacteria, especially E. coli. And so common to all types of shock is circulatory collapse, hypotension, and tissue hypoxia. So you can assess oxygenation of tissue by means of pulse oximetry, and you would see that these patients have low oxygen reading by pulse oximetry, and this leads to multi-organ failure. So they will start by having problems, let's say in the case of the current virus, the coronavirus, the COVID-19, they start to have problems in the lungs, which affect oxygenation, and then so they develop on top of that a form of septic shock, and so there will be sequential failure of organs, which is not predictable always, but they would have also problems arising in the kidney, in the liver, in the brain, and so we call this process multiple organ failure, and then consequently it will lead to death. And so the classical example that we try to understand the concept of septic shock is lipopolysaccharide from gram-negative bacteria. So the lipopolysaccharide binds to monocyte and macrophages and neutrophils and leads to release of cytokines, which is mainly tissue necrotic factor, interleukin-1, which induces production of interleukin-6 and interleukin-8. And then so you have this feedback loop, positive feedback loop, which also results also in release of other mediators such as nitric oxide and platelet activating factor. And so nitrous oxide, remember, causes vasodilation. Platelet activating factor activates platelets, so it leads to formation of very small thrombi in the bloodstream, which further injure endothelial cells. So in low quantities, this process happens, and so it will result in controlled inflammation, which is local inflammation, so it doesn't spread to the whole body. And so the acute inflammatory response in this setting in low quantities, it's helpful. It localizes the inflammatory response, clears the cause of infection, and so everything after clearing returns back to normal. In moderate quantities, you will start to have more systemic effects where, so the cytokines here, especially TNF and interleukin-1, reach the systemic circulation, and in the brain they reach the centers that control the temperature, which will be expressed as fever. In the liver, it will lead to release of acute phase reactants, especially C-reactive protein and ferritin. In the bone, it will induce left shift, where you have release of precursor or premature forms of leukocytes. And what's happening now is that the body is trying to recruit different organs into fighting this organism. Okay, so this will lead to systemic effects in moderate quantity. However, if you have high quantities, the favors would shift toward this being a helpful process, the inflammatory systemic response, into a counterproductive process. So you'd start to have suppression of cardiac myocytes, leading to low cardiac output, also systemic vasodilation, leading to low peripheral resistance and low blood pressure, injury to endothelial cells and thrombosis. DIC is disseminated intravascular coagulation. And so they have so in DIC, they have what we call consumptive coagulopathy, okay? So there is activation of platelets, activation of endothelial cells, so small thrombi develop. And at the same time, these small thrombi develop. They're very small, too small to cause obstruction of the arterial supply, but they lead to consumption of platelets and consumption of coagulation factors. So these patients who have DIC have a tendency for bleeding. And in the lungs, the effect will be acute respiratory distress syndrome. And we call this, a conglomerate or a group of symptoms, septic shock. Okay, septic shock. So pathogenous septic shock, so high levels of lipopolysaccharide produce a syndrome of septic shock, which is characterized by systemic vasodilation, diminished myocardial contractility, widespread endothelial injury, and activation of leukocytes, activation of platelets also, leading to activation of coagulation system, and as I mentioned, DIC, and then this will lead to multiple organ failure. Clinically, these patients will present with hypotension, tachycardia. So patients who present with hypotension and tachycardia, first thing they want to evaluate for treatable causes, such as hypovolemic or cardiac shock. So hypovolemic shock, they will give the patient a fluid bolus if the patient doesn't have pulmonary edema, and they would see the response. So if the patient responds and blood pressure normalizes and tachycardia disappears, then this is most likely hypovolemic shock. Cardiac shock, they would assess the cardiac function, do electrocardiogram, and do cardiac enzymes. Okay, and also they would do echocardiogram to assess the function of the heart. And so these patients, however, I mean, there are clinical features that can help us sort of think about or consider septic shock. And so usually hypovolemic shock and cardiac shock patient is tachycardia, cool, clammy. Clammy means pale, looks pale, with cyanotic skin and tachypnea. And why do we have cyanotic skin? Because of hyperperfusion. So the body will try to maintain the blood pressure as much as possible by increasing the cardiac output and also by increasing peripheral vascular resistance. So that's why you see these features in the skin, cool, clammy, cyanotic skin. However, in septic shock, because of production of cytokines and production, as I mentioned, of nitric oxide, what will happen, there will be vasodilation. So these patients will have warm, flushed skin. In addition to low cardiac output, also oliguria and anuria. Oliguria will which is defined as production of less than 400 ml of urine output during a day, indicates hypoperfusion of the kidneys. And then, I mean, finally, consequently, if not treated, not reversed, will result in death. And so this is as far as septic shock. So two other types of shock, which are less common, but you have to know them. Number one is neurogenic shock, and number two is anaphylactic shock. Neurogenic shock results from anesthetic accident or spinal cord injury, in which the problem is with peripheral vascular resistance. So there is loss of peripheral vascular resistance and pooling of blood in the peripheral areas of the circulation. And so what will happen is that the heart will try to increase cardiac output to try to overcome and maintain the blood pressure within range. But I mean, this effort might be impeded if this occurs over a wide area of the body. The other cause is anaphylactic shock. So you remember type 1 hypersensitivity reaction, which is characterized by systemic vasodilation and increased vascular permeability as a result of IgE hypersensitivity reaction. So these two less common types of shock are characterized by vasodilation, in contrast to cardiogenic shock and hypovolemic shock, which are characterized by vasoconstriction of peripheral circulation or increased peripheral vascular resistance. Septic shock is characterized by vasodilation and decreased vascular resistance. And so if you have any other questions, please don't hesitate to contact me through email. I'm more than happy to answer your questions. I hope you understand the terminologies, and as I said, most important is that you understand the definition. Just make sure you know the definition very well and look at the mechanisms after you know the definition, and it will be an easy topic. And I'm hoping that even with this crisis that we're going through in COVID-19 issue, that you would at least please review this topic very well, because your further studies into different body systems and different disease conditions will be based on understanding these basic mechanisms. And just to give you this information, my email is drpathology@gmail.com. You can call me on my cell phone. You can send a WhatsApp anytime, no problem. Even if I cannot answer you immediately, I will write you the answer on WhatsApp. My phone number is 0565 733 999. And thank you very much. Stay safe.